Welcome to the e-learning module on pathology of ovarian tumor. In this session, I'll be talking about approach to diagnosis of ovarian tumors. The learning objectives are to know stepwise diagnostic approach to a case of ovarian tumor, to know the role of various investigation in evaluation of a ovarian tumor, to list the tumor markers and where they are positive, and to know various screening tests available for ovarian tumor early diagnosis. So as we all know from previous session, there are three main categories in primary ovarian tumors. So they are epithelial tumors, sex stromal tumors, and germ cell tumor. In addition, there are the fourth types of tumors which are not specific to the ovary. So they can be soft tissue tumors or lymphomas, and also the tumors which are metastasized to the ovary from extra ovarian primary sites. So more than 70% of ovarian cancer have extensive extra ovarian tumors spread at the time of diagnosis. So this is mainly because of the symptoms of ovarian tumors are very vague and non-specific, and they do not prompt for early diagnosis. So whenever we are evaluating a case, so we have to go in a stepwise manner. So these steps are primary history, followed by physical examination, imaging analysis, laboratory test, which includes FNAC, frozen section, various blood tests, and also histopathology on biopsy or on excision specimen. And we will be talking about screening test and also genetic test for those who are having high risk of ovarian cancer. So coming to history. So what is the significance of history? It will help determine whether the ovarian cancer should be considered as a cause of patient's symptoms or not. So depending upon the age, our DD should be, if the patient is young or children, the most important diagnosis is germ cell tumor. So if she is a middle age woman, epithelial tumors or sex stromal tumors will be the DD. If it is a old age female, mainly it will be epithelial tumor, that too malignant epithelial tumors. So presenting symptoms of ovarian tumor on gynecological malignancies can be vague. So which include back pain, fatigue, abdominal pain or bloating, constipation because of pressure over the colon, or urinary symptoms, urinary frequency, or she can present with the pelvic mass. So the exception for late presentation in ovarian tumors are sex stromal tumors. So they usually present at early stages because they are usually associated with hormonal manifestation. So 70% of sex stromal tumors are diagnosed as stage 1, and the symptoms related to hormone production can be menstrual irregularity, hirsutism, or acne. So they are the signs of virilization. So family history also very important in ovarian cancer. So those who are having close relatives with breast cancer or ovarian cancer, pancreatic cancer, or prostatic cancer are known to have some familial cancer syndrome. So they have to be screened for genetics testing, or screening test also important. So once you suspect the ovarian tumor based on the history, so you have to do thorough complete physical examination. So in physical examination, the most important part is rectovaginal bimanual examination with the empty bladder. So this help in evaluation of pelvic or abdominal masses. But in obese, it has got limited accuracy. So the in obese patient, pelvic mass can be easily missed. So you have to examine for endocrine dysfunction also, like signs of acne or hirsutism, and also paraneoplastic syndrome like osteoarthropathy or clumping, and lymphadenopathy for metastasis, or presence of pleural effusion, umbilical mass, which is system Mary Joseph model, and metastatic skin nodules. So based on the pelvic examination, if there is a palpable pelvic mass, we have set of DDs. It can be gynecologic DDs or non-gynecologic disorders. So under gynecologic DDs, the most common ones are benign. So like ectopic pregnancy, endometrioma, functional hormonal cyst, leiomyoma, or the tumors like mature teratoma, cystadenoma, serous cystadenoma, which are the common group of ovarian tumor. So among non-gynecological DDs, the most important one is appendiceal abscess, or it can be diverticular abscess, some nerve sheath tumor, paratubal cyst, or pelvic kidney, or some malignancy from gastrointestinal tract. So these are the set of DDs for pelvic mass. So once you know there is a pelvic mass, you have to go ahead with imaging analysis. So pelvic ultrasound is the most useful technique for diagnosis of adnexal mass. In that, transvaginal ultrasound has got high sensitivity and it is cost effective also. So transvaginal ultrasound is the preferable ultrasound technique. So it has better resolution than abdominal ultrasound. So it will assess the ovarian architecture and vascularity, and it helps in differentiating solid masses from cystic mass. So solid mass means you have to suspect some ovarian cancer. So sensitivity and specificity for transvaginal ultrasound is 86 to 90% sensitivity and specificity 94 to 96%. So that is quite effective. So based on ultrasonography, there are various criteria for suspicion of malignant tumor. So those are size of more than 10 centimeter, the septum thickness of the cyst, yeah, more than 3 millimeter, cyst wall thickness of more than 3 millimeter, the papillary excrescence, the height of which more than 3 millimeter, presence of solid part. All these tell that there is some suspicion in a ovarian tumor. So they have to be further evaluated to rule out malignancy. So other than ultrasound, other imaging techniques are CT, MRI and PET scan. But for screening test, it is not usually indicated because the CT and PET has got radiation exposure, and also they are quite expensive compared to ultrasonography. So coming to next set of investigation, which is laboratory test. So in laboratory test, the most important ones are tumor marker. So what are tumor markers? These are biochemical assay which are analyzed for tumor associated enzymes, hormones or any other markers which are associated with the tumor, which are there in the blood, but they lack the sensitivity and specificity which is necessary for diagnosis of cancer. So if it is used with other tests, they contribute to detection of cancer. So they can also be used to know the response to various therapy given for the ovarian cancer, and also for detecting the tumor recurrence. So these are the set of markers depending upon our DDs. So if you are suspecting a epithelial tumor in an old age woman, the markers used can be CA125, HE4, which is a recent marker, that is human epididymis protein, CEA, carcinoembryogenic antigen, or CA199. If you are suspecting sex cord stromal tumor, the markers can be inhibin A or B. If it is germ cell tumor, the set of markers are serum alpha fetoprotein, beta HCG or LDH. So the selection of tumor markers depends on our DDs. CA125 is used for epithelial ovarian cancer. CEA mainly detects mucinous ovarian cancer. HCG is positive in embryonal carcinoma or choriocarcinoma, which comes under germ cell tumor. Inhibin A, most helpful in diagnosing granulosa cell tumor. LDH, helpful in dysturbinoma. Alpha fetoprotein for yolk sac tumor, or it can be positive in embryonal carcinoma also. So coming to individual tumor marker, CA125 is a glycoprotein. The upper limit is 35 units per milliliter, and it can be used for screening of ovarian cancer in pre or postmenopausal patient, but it has got low specificity because it can be elevated in various other condition also, which can be physiological or pathological. Physiological, like during menstruation or during pregnancy. Pathological can be various endometriosis or inflammatory diseases of the peritoneum, and also in other cancers of like pancreas, colon, lung, or breast cancer. So it has got very low specificity. Next marker is beta HCG, which can be increased in hydatidform mole, which is a molar pregnancy, choriocarcinoma, or embryonal carcinoma, which is a germ cell tumor. It can be also elevated in pregnancy. Alpha fetoprotein, which is a marker for germ cell tumor, but it can be elevated even in hepatocellular carcinoma. The reference value is less than 10 to 20 nanograms. Lactate dehydrogenase is a marker for dysgerminoma, but it can be also elevated in embryonal carcinoma. HE4 is another new biomarker. So it is considered as a current marker for ovarian malignancy, especially which can be positive in endometrioid type of ovarian cancer. C is a glycoprotein. It is not specific for ovarian cancer. It can be seen in colon cancer, lung cancer, or any inflammatory condition like endometriosis. 30% of the ovarian cancer, especially mucinous or seromucinous type of carcinoma, can show elevated CEA. Next marker is a CA99, which is a carbohydrate associated antigen. This is a marker for pancreatic cancer, but it can be used along with CA125. So, because this is also elevated in mucinous type of ovarian cancer. So you can pick the marker, tumor marker, which should be analyzed based on your DDs depending upon the clinical presentation. Suppose if the mass is cystic with the few solid areas and it is seen in above 30 years age group, and if there is some peritoneal mets, you will be suspecting epithelial tumor. So the markers will be CA125 or CA99 or carcinoembryogenic antigen. If it is a postmenopausal woman, it is a solid ovarian mass and patient present with some hormonal manifestation like virilization, hirsutism. The suspected DD is sex stromal tumor. So we can select markers like inhibin or estrogen, testosterone, which are hormones. So if it is premenarchal or children with some unilateral or bilateral solid mass, the main DD is germ cell tumor. So the marker which can be selected are alpha fetoprotein, HCG, lactate dehydrogenase. And if it is bilateral mass with the history of some malignancy in the GI tract, the DD is metastatic GI tumor. In those cases, we can assess CEA, that is carcinoembryogenic antigen. So the set of markers to be selected depends on your differential diagnosis. The next type of test is FNAC. So FNAC is fine needle aspiration cytology. In this technique, you will be using a syringe and needle to aspirate the content from the tumor. But it should be usually avoided in early stage tumor because there are chances of spreading of the tumor to the peritoneum. So this is should be avoided in early stage cancer. But if it is an inoperable cancer and if the patient is not able to undergo surgery because of some other health issues, you can diagnose using FNAC. The additional thing is peritoneal fluid cytology. So this is mainly used for staging procedure. So if there is presence of ascites which is having peritoneal metastasis, means the stage will be stage 1C or 2C. So it will go for C in staging. So next investigation is frozen section analysis, which is very helpful intraoperative consultation. So this is an intraoperative consultation, which will help differentiate between malignant and benign pathology before or during the surgery. So depending upon the frozen section report, the surgeon can decide what type of procedure to be done. So if there is doubt regarding whether malignancy present or not, intraoperatively they can send the sample for diagnosis. So this also will provide additional information like margin status, which help in clearing the which helps in debulking surgery. Next is histopathology. So histopathology is tissue diagnosis of the tumor. It can be done on tumor biopsy or in a specimen of debulking surgery. So what are important when analyzing the tissue histopathology are specimen integrity, the type, the tumor type, histologic type, which can be confirmed by ISC, tumor grade, which is important especially in serous tumor for prognostication, and also tumor stage can be confirmed by histopathology. So next is genetic testing. So the role of genetic testing is diagnosis of hereditary predisposition to cancer. So especially if there is germline mutation in tumor suppressor genes like BRCA, BRCA1 or BRCA2. So if you know that using a genetic testing patient is having this mutation, it is known that they should undergo screening program, repeated aggressive screening program, and also prophylactic surgery like salpingo oophorectomy, and the relatives also should be counseled because they are also at risk for gynecological malignancy. So such test might require sequencing of the entire gene for looking additional gene mutation. So coming to screening test. So screening tests are important if the woman is having risk of ovarian cancer, like if she is having some family relatives, close relative with history of gynecological malignancy or non-gynecological malignancy, like hereditary non-polyposis colon cancer, that is Lynch syndrome. So current standard for the procedure is risk reducing salpingo oophorectomy if they are having familial syndrome. So for early diagnosis using screening techniques, always combination of investigations are indicated because none of the individual tests have got 100% sensitivity or specificity. So the set of investigation what we are need to do is bimanual pelvic examination, ultrasonography, MRI, CT scan, PET scan, and also the tumor marker. Most important one is CA125. So no single test is having 100% specificity, but most sensitive and specific test is MRI. But it is not affordable to undergo MRI investigation repeatedly as a screening procedure, and also availability is a issue. It is not available everywhere. So USG is the most cost effective screening technique. So what are the limitation of screening? So cost and accessibility is the main limitation, like CA125 or regular CT or PET scan. The cost feature is also important and accessibility also important. In addition, CT and PET has radiation exposure also. So as screening requires repeated investigation, it is not indicated. So cost effective investigation is transvaginal ultrasound. MRI has got excellent sensitivity, but it is not usually indicated because it is expensive. So coming to emerging technology, which is a liquid biopsy or circulating tumor DNA. So this is analysis of biological fluid such as blood to detect presence of circulating DNA. So it is a minimal invasive procedure which can be used for early detection of the cancer or monitoring of response to treatment or assessing the progression of the disease. So contrast to traditional tissue biopsy, which is an invasive procedure, this is a liquid biopsy is a minimal invasive procedure. So it can be utilized for repeated investigation. So the difference between liquid and traditional tissue biopsy is liquid is minimally invasive, traditional is an invasive procedure. This is easily repeatable, but this is not easily repeatable. So the tissue sample which can be used can be blood or uterine aspirate, and the clinical application is diagnosis for prognostication, therapy selection, and also monitoring after the therapy. So to summarize, approach to diagnosis requires the set of tests, sequential steps like pelvic examination, biomarker like CA125, and also in addition other markers, imaging analysis like transvaginal ultrasonography, CT scan, MRI or PET, biopsy which can be tissue biopsy or excision specimen, and also genetic testing to rule out some genetic mutation. These are the references. Thank you.